Economic news dominates the headlines these days. That prompted us to ask, what do we really know about the economics of healthcare? I'm Andy Reynolds. Today on Quality Matters, we review what we've learned about healthcare economics from recent guests. In episode 15, healthcare economist Sanjula Jain, Chief Research Officer at Trilliant Health, gave us a valuable education about the macroeconomics of healthcare. Our conversation focused on her firm's impressive report titled Trends Shaping the Health Economy.
Your report mentions that costs cannot increase by more than 50% while demand is flat. This reality is unsustainable. Unpack that for us, please.
The U.S. health economy is at its breaking point. There's data in the report, but also everywhere you look, Americans' number one concern when it comes to healthcare is the cost of care, affordability. They're delaying care because of the cost. That is really bankrupting America. And then we don't see improvement in health outcomes. I could argue that it's unsustainable just based on the pure cost of care and how much that we're having to pay. But it's also unsustainable when you factor in what are you getting for the dollars that we are putting into the healthcare system. And I would argue really not much when you think about health outcomes.
The focus of your report is value. My simple equation for value is that value equals quality divided by cost. Is that a smart way to think about value?
I would encourage folks to think about value for money, which is more nuanced. We all know what value for money is in our day-to-day lives. Let's just take hotels, for example. Marriott is a known brand. You can make a reservation at a Courtyard Marriott, and you can make a reservation at Ritz-Carlton, both part of the Marriott umbrella. You know what you're paying for. I'm not going to get the same amenities at the Courtyard as I would the Ritz. But there's a difference in the cost. Same thing in the car industry. There's a difference between the Honda Accord or Lamborghini. The same thing should apply in healthcare. Value is in the eye of the beholder. Everybody has a different value equation. The asset can be quality and cost, but for some people, convenience is a component. At the end of the day, are you getting the value that you ascribe for the money that you are paying? That's really what it comes down to.
You say in the report, value for money is not to be confused with value-based care. What do you mean?
Value for money is the ultimate consumer of the service is going to determine that value based on what they are paying. Value-based payment, it's different because value-based payment is ultimately a reimbursement scheme that doesn't change the total cost of care. Value-based payment is really a policy scheme focused at the provider level, which doesn't even affect the patient or consumer. It's one pool of dollars that is being reallocated. Providers are just reallocating those dollars, not actually reducing the total cost of care. Who is benefiting doesn't actually translate down to the patient or the consumer.
Okay, so I'm getting from you that there are big differences between terms that sound like they could be mistaken as synonyms. So I'd like to read off these terms to you and get your quick evaluation on each of them. Value for money. How do you rate it?
Great idea.
Okay. Value-based care.
A failing idea.
Value-based payment.
Failing idea.
Okay, so for those of you keeping score at home, we have 2 fails and 1 great idea from Sanjula. Value-based payment, fail. Value-based care, fail. Value for money, Sanjula likes that idea. Sanjula, these ideas sound so similar, so how should we think about the differences?
It comes down to the level at which the payment incentive is operating. In value-based payment, the incentives, it's operating at the provider level. You're dealing with payment from the government to hospitals and physicians. It's just a reallocation of money. Medicare spending is not decreasing as a result of value-based payment incentives. Value for money is, like we talked about it with hotels and cars, affects the consumer of the services, not the provider. Value for money is more of how we operate every day in our lives, where the providers have to uphold the value the consumer is asking for. Value-based payment ultimately doesn't reach the consumer of that service.
Got it. Thank you for teasing that apart. Let's get into another area where terms that sound similar mean different things. Your report draws a distinction between optimizing value and maximizing value. What's the difference?
Let me give you an outside healthcare example. Think about Costco. They are optimizing value. They leave money on the table for individual goods in some instances. They're not thinking about every single interaction to increase profit. There is a trust when you go into Costco. No matter what you are looking at, it's going to be the best rate possible, competitive price or lowest price. They have a set rate of a margin that they will charge. So a tray of muffins, let's say they purchase that for $2 and that set margin says, okay, we're going to charge $5. Even if they know they could get away by selling it for $7, they say no, Costco policy is we're going to cap it. They are optimizing value knowing that even though we could make more profit, they are not breaking trust. There is that loyalty with the customer. The result is that consumers probably end up buying more goods. So the incremental revenue they lost on muffins, the $2 additional they could have charged, ends up balancing out all the other things that the shopper ends up buying.
Okay, so Costco is an example of a value optimizer. What's happening in healthcare?
The health economy is focused on maximizing value. Maximizing value is maximizing revenue. I will pick on my pharma friends. If pharma rethought how to get Americans using generic drugs, they may see a decline to their total revenue, but in the long run, that's delivering more value to their target customer, which can realize different forms of revenue or loyalty in other ways. That's kind of the difference between optimizing and maximizing, where right now the health economy does every single thing they can do to maximize that revenue. How can I get the most reimbursement based on this policy scheme? How can I bill for the most things? It should be more about the core things I need to deliver, almost independent of what I could bill for. That's a big factor in making the health economy so unsustainable.
A major conclusion of your report is that stakeholders who focus on value optimization will have a competitive advantage. How so?
There's more people competing for a shrinking pool of profitable patients. How you compete in the negative sum game is you lose less. Everyone has to give up something, or we're going to lose a little something than what they're used to having 10, 20 years ago. You basically have to figure out how can you optimize within that. If you are a health plan or a provider group, your ultimate customer is the employer. You have to think about, how do I deliver more value than my competition? You're going to have to start doing things like the Costco model to stand out and compete, because there's competitive pressures we haven't seen before.
You mentioned healthcare as a negative sum game. My memory is the negative sum game is where everyone loses and the prize is worth less than all of the inputs or the costs invested. Are things really that dire?
Yeah, I do think it's that bad. I don't think the industry has woken up to what is happening at a macro level. When you get outside your silos and look at how this is playing out, it's not promising. Excess mortality, cost of care, health status. It's not just staying bad. Things are getting worse. If I could leave folks one thing, it would just be that this point in time is unlike no other. This should be a wake-up call.
Turning from Sanjula Jain's education about the macroeconomics of healthcare, we look to Tennessee for specific examples of value-based care in action. In episode 17, I spoke with Brittany Cunningham, Vice President for Episodes of Care in Population Health at Vanderbilt University Medical Center. Vanderbilt University Medical Center won an NCQA Health Innovation Award for something called My Health Bundles. What are My Health Bundles?
My Health Bundles is a value-based care program that Vanderbilt University Medical Center created in 2019 based off of our experience with Medicare and Medicaid. We created our own episode of care bundle program that offers comprehensive solution with predictable care and sells them directly to employers.
And what problem did My Health Bundles set out to solve?
We think about it from three different perspectives. For the employer, we were trying to lower cost when there was a lot of variability in their expensive cost. The benefit to the patient is a seamless experience. They know everything is taken care of and there's no surprise bills or surprise costs to them. If you are under that high deductible health plan, you have to pay your federal minimum. But with a PPO plan, we are able to provide this program at zero out of pocket for a patient. Most of the time, the patient is going to get this with low to no out of pocket costs. And then we were trying to help providers provide evidence-based care solutions that they wanted to provide, which sometimes were held back by insurance rules, preventing them from doing what they knew was best for patients.
Many of our listeners are familiar with the Medicare and Medicaid bundled care arrangements that you mentioned. How are the commercial bundles that you sell directly to employers different?
Medicare and Medicaid provide a payment model, and we had to create the clinical model underneath it. With this My Health Bundles, we create the clinical model first with the providers and then put a payment model around it. That helps align the providers to give the best clinical care, and they're more satisfied with this model.
The name of your office or your department is Episodes of Care. How does focusing on episodes factor into how you build your bundles?
An episode of care always has a start and an end. We go to the clinicians and we say, what is a start and an end of a clinical pathway that we can focus on? Maternity care is a great example. There's always a start and an end to a maternity episode. You have your first prenatal appointment, and then we cover out to 3 months after delivery. All of the services in that maternity pathway are included for the mother and the baby. Another example is a total joint.
When you say total joint, is that total joint replacement?
That bundle, yes, is a total joint replacement for your hip or your knee. There's clinical evidence of when that pathway should end. Some people argue it's 30 days. Some people argue it's 90 days was how much risk we were willing to take. So it's the first consult visit to 90 days after surgery. So all of our episodes have a beginning of coverage and an end of coverage.
You mentioned predictability for the employer. Talk to me about why predictability is important.
Yeah, this is really a key to the program. There is a locked-in utilization by doing a bundle payment and having that locked-in price. One of the best examples is maternity. A purchaser is paying for a locked-in C-section rate. Whereas if you go to any other hospital, you are going to pay for as many C-sections as that provider is providing. We have seen a lot of variation between providers and between hospitals. We have a locked-in C-section rate of 30%. Other providers, C-section rate was 40%. For employers, they're paying more by not using the bundle. The predictability of using the bundle is you know what you're paying for. You've got that set price. We're not surprising you with utilization.
You say we're not surprising you with utilization. Now, some people might hear that and say, okay, but are you skimping on care? Are you reducing warranted utilization? What do you say to that?
This program is about aligning the incentive to the right people. We have found that by aligning the clinical care and what the patient needs and what the provider wants to provide. We're not cutting anything out. We are incentivizing the provider to do what is appropriate for the patient.
Economics has been called the science of getting the most out of life. In episode 9, we used an economic lens to learn about care for people at the beginning of life. That conversation was with Dr. Tiffany Inglis, National Medical Director for Women's and Children's Health at Carelon Health. Carelon is part of Elevance Health, and Elevance knows a lot about pregnancy and childbirth in the United States. Tell us about that, please.
At Elevance Health, we care for about 12% of the nation's births. It's about 1 in every 8 babies born.
A little less than 50% are Medicaid deliveries and a little more than 50% are commercial. So it's a lot of babies.
I imagine at that scale, you see and learn a lot. How do you think about quality improvement when you're dealing with such large numbers?
When we think about the opportunity that affords, we're looking at around 500,000 births, depending on the year. And so really been focused on how do we, with that volume and scale, think about improving outcomes. We need to be addressing racial disparities. We need to be addressing that not all moms live in places where they have access to care. We call those maternity deserts. My goals of getting into this work is what works to fix these things, and then how do we scale that in the 1 in 8 births, 12% of the births? How do I scale things that are working and make sure we're getting them to everyone as quickly as possible?
Can you explain the origins and the purpose of your program, please?
Provider enablement is the blanket term. The team are called OB practice consultants. It's a group of clinicians, nurses for the most part, who work together to support providers. The person on our side has very much a clear line of sight into all of the member programs and options that they have available to them. They are linked to the plan, but they are the point of contact for the OBGYN or midwife, and really the point of contact for their staff to be able to say they need something. We align a person to these providers to be the touch point, share data on outcomes, C-sections, preterm birth rates, who still needs to get a postpartum visit, but also then have the providers say, I'm taking care of Andy and he really needs XYZ. Does he have a benefit for that? How do I get him that support?
So OB practice consultants are the practitioner's coach or go-to inside the health plan. How does all this relate to value-based care?
Over time, we've partnered with our value-based care team, and they are also the person that helps support our value-based care providers. They don't have to be in a value-based care contract to get the support from the practice consultants, but when they are in that relationship, they get deeper data, deeper knowledge that can help close care gaps, make sure patients get care they need, make sure patients get services available that maybe the doc doesn't know they have. We're working within our value-based care solutions across the lines of business and making sure that both value-based care aligned physicians and not aligned are getting the support from this team. And then the other role we play is that then as we approach providers about being in value-based care, this team is really that front line that can help recruit and answer questions.
Can you tell us how the program has changed?
Elevance Health launched the obstetrics practice consultant program 2015 with one person for a couple of years. Now we're at almost 40. What we started with when we were a smaller team was focused around Medicaid. Until 22, that was our only focus. We expanded the program to start supporting our commercial deliveries. We are working with the same docs because most OBGYNs are delivering babies that are Medicaid members and commercial members.
Okay, so substantial growth. What about your impact?
When we created the offering, we really didn't know if it would work. It's different than anything else we ever offered. Our providers are terribly happy with the program, 95% happiness from our providers. And the program has grown not only because people like it, but because this has driven huge changes, a significant improvement in low birth weight babies. It's 20% in our recent evaluation. 20% fewer low birth weight babies were born, a 12% reduction in preterm birth. Those are big numbers, and a significant improvement in prenatal visit compliance, postpartum visit compliance. The thing that's been most eye-opening is we can really impact outcomes. This has been our biggest lever.
I think that's a good place to end it. Sanjula, Brittany, and Tiffany highlight the need and the potential to improve healthcare. Despite their varied approaches, they all aim to increase patient value, improve population health, and build a sustainable economic foundation. Their insights can help us achieve these goals.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.